Good afternoon or good evening, everybody. Welcome. Thank you for joining us today. My name is Sandro Galea, and I have the great privilege of serving as Dean of the Boston University School of Public Health. I'm here today in my capacity as chair of the Rockefeller Boston University 3D Commission. The 3D Commission, with the 3D stand for determinants, data, and decision-making, was started as a partnership between Rockefeller Foundation and Boston University in the beginning of 2019. The vision behind the commission was to say, where is our thinking on the social determinants of health? Where has it advanced to? And how can we get better at measuring social determinants to the end of making decisions that improve health, that take the social determinants into account? The idea really emerged from recognizing that our global conversation on the social economic determinants has advanced quite a bit in the past 5 to 10 years, building really on a quarter century of scholarship and conversation about them. And it was really time to think about the next phase. And the next phase was, how do we make sure that when policy decisions are made, social and economic determinants are borne in mind? To do this, we assembled a global commission with 24 commissioners from around the world. And the commission deliberated for a 2-year period, emerging with a report that was released at the UN General Assembly meeting about 3 weeks ago. Now, I mentioned that the commission started at the beginning of 2019 because the timing here is relevant. Because of course, at the beginning of 2019, none of us had ever heard of COVID before. By the time the commission launched was the end of 2019, beginning of 2020, the commission's work unfolded against the backdrop of COVID. And if there was anything that ever made it clear how much social determinants mattered, it was COVID. Because for anybody who was paying attention, it was very clear that COVID was fundamentally, yes, an infectious disease, but it was a disease that reflected underlying social and economic drivers more than anything else. And really, COVID revealed what we knew already, that there is no health without paying attention to the underlying social economic structures. There is no health without taking into account characteristics of place, of the places where we live, where we work, where we play. And that decisions that we make about those places, about economies, about our social context, fundamentally shape the health of populations, the health of everybody, but in particular, the health of marginalized groups. The Commission's report articulated 6 principles and 4 recommendations that fundamentally aim to push forward this conversation. And I would encourage anybody here to take a look at the Commission's website and to download the report. And the intention behind the report was to start a conversation, was to say, can we move forward to the next stage in thinking about social determinants? Can we get better at understanding those determinants so that decisions made about transportation, about housing, about the economy, all keep health in mind, so that together we can make decisions that improve health for populations worldwide. As part of getting these ideas out there, as part of encouraging this conversation, we have been hosting a series of these 3D conversations, where we have been inviting distinguished scholars, distinguished practitioners, distinguished leaders to talk about the ideas behind the Commission's report, to really just talk about what we articulated in the report, but broadly speaking, to talk about their intersection with the ideas in the report. And these conversations are not meant to be dispositive. We're not offering specific solutions, but they are intended to keep the conversation going and to encourage anybody who then listens to these conversations to keep the conversation going in their own forum. So today, I'm really delighted to have with us someone very special, Dr. Julio Frenk. So let me read the formal introduction for Dr. Frenk. So Dr. Frenk currently is president of the University of Miami. Prior to joining the University of Miami, Dr. Frenk served as the dean at the Harvard T.H. Chan School of Public Health and the Angelopoulos Professor of Public Health and International Development, a joint appointment with the Harvard Kennedy School of Government. Dr. Frenk has an illustrious career in public health. He was Minister of Health of Mexico from 2000 to 2006, where he pursued an ambitious agenda to reform the nation's health system and introduced a program of comprehensive universal coverage, which expanded access to healthcare for 55 million previously uninsured persons. Dr. Frenk's career has included leadership positions in all relevant aspects of public health and higher education: research, teaching, analysis of public policies, institution building, international cooperation, and national public service. He has been involved in various initiatives to reform higher education. And on a personal note, Dr. Frenk has a long time been a friend and a mentor. I've learned a lot from Dr. Frenk, both reading his writing as well as in conversations with him. So Dr. Frenk, Julio, it's a pleasure to have you. It's an honor to have you with us.
Thank you, Sandro. It's my pleasure.
So let me start with a bit of a general question, if I may, and really get your overall reactions. You know, my initial premise that I started this conversation with is that our thinking about social determinants has evolved quite a bit in the past, I said 5-10 years, building on 25 years of scholarship. Can you reflect on the arc of our thinking about social determinants as it's intersected with your career, because your career has really spanned this time frame. Where were we, where are we, and where do you think we're headed with a social determinants scholarship and action agenda?
You know, the triangle of the 3D is probably deciphering that has been at the core of many of the most fundamental advances and debates in our field. And as you say, I mean, there's a long tradition, intellectual tradition, linking the health of individuals to the conditions in which they live. But it's not only recently that we've developed systematic and a systematic approach. I mean, the research actually starts in the 19th century, documenting the health impacts of the living conditions of working class members, especially during the rapid industrialization of Europe, and then extends throughout most of the 20th century. But I think a watershed moment is, of course, the Commission on the Social Determinants that Sir Michael Marmot chaired and co-chaired actually with President Lagos of Chile. It was a very interesting case and an example of leadership, by the way, in the Americas in thinking, but that a sitting head of government and state, as President Ricardo Lagos, co-chaired that with a very distinguished scholar as Sir Michael Marmot. I think your commission is a very, very important step forward because it puts in highlights that connection with decision making. We have been talking about evidence-based policy and evidence-based clinical practice, but that idea of having rigorous data driving also the conversation around social determinants, I think, has been lagging, and I think your commission really filled that gap. Now, as I look at that triangle, you know, the first piece is, of course, the relationship between the social determinants and what we do mostly in the health system. That's been a matter of great debate. And of course, we now know, and there's very, very ample evidence throughout this whole intellectual trajectory that I just described, of the determining effect of some social conditions like education, like work, like environmental circumstances, housing, etc., on health. Now, we also understand that the relationship operates the other way around. And I think the pandemic was a great example and reminder of the power of that mutually reinforcing codependence. Because, you know, we've known for a long time that economic conditions are a determinant of health. But what we've seen now in action is how a health event, like an outbreak of an infectious disease that then becomes a global pandemic, how that has been a major determinant of economic performance, economic growth, triggering the largest economic recession in a century. So that's one progress, I think, where we've understood better the bilateral directionality, the bidirectionality of that crucial relationship. The second piece that I would say has been progress is, I think, in the early discussions on social determinants, there was a little bit of a dichotomous thinking. Mm-hmm. And people would either emphasize interventions on the social determinants to improve health or acting at the level of the formal healthcare system to improve health. And that was, especially in the 1970s and 80s, a vigorous debate. In its worst expression, I think, led to what has been called the doctrine of therapeutic nihilism. Mm-hmm. The idea that no matter how much you do to provide healthcare, it really doesn't matter because it's all a matter of determinants. I think we've gone past that, and we understand that actually the way the health system gets structured and funded is itself a social determinant. And I think we've moved past that dichotomous thinking that was very much at the beginning. And we understand that the structure, functioning, and the political weight of the formal healthcare system is in and of itself a social determinant because it's a social construct and subject to the dynamics, the political dynamics of a society. And then the third piece, which I think you really make an important contribution, is bringing the data into that and really spelling out how interventions at the level of social determinants can be as rigorous, sometimes even based on random designs, as clinical interventions. And the idea of intervening at the level of the determinants and generated valid information that then is translated so that it can be used for policy making. I think that's the third piece here. And so on all those three vectors, I think we have made quite a bit of progress.
Yeah, that's actually really interesting. So let me go to sort of some things that you've mentioned in the past, because you've long sort of talked about the role of stakeholders in being involved in decision making, and you've written before about that stakeholders involved have to reach a consensus about the what before they can arrive at the how. So I was wondering if you can tie it into your practical experience when you were Minister of Health in Mexico and you led health system reform. Can you talk a little bit about how the what and the how there actually realized themselves, and how did that intersect with social economic realities for you?
Well, you know, I was very privileged to serve as the Federal Secretary of Health in Mexico from 2000 to 2006. I was at the World Health Organization when Dr. Grove Rutland was the Director General, and I had created a new area called Evidence and Information for Policy, speaking about using data for policy. That was a whole new area that led to the most famous product of that was the World Health Report 2000, which for the first time actually did a ranking of countries according to the performance of their health system. It was very data intensive. And at that point, that was a historic election, the first fully democratic election in Mexico. And the president who got elected, was looking for new faces. I didn't even vote, although I wanted him to win, because I was in Geneva. But he actually looked for experts. Today, it might seem like a crazy idea when we see cabinets bringing in billionaires and things like that. There was that idea that if you wanted new faces in politics, you could actually bring, for certain ministries like health, experts. So that's how I ended up in that position. And so it was expected, and that was my signature, that it was going to be very much an evidence-based reform. And what I discovered is, I had the intuition, but I actually saw it in action, is the power of good evidence to bring about political consensus. Because again, that's often a false dichotomy between political realities and technical. The political and the technical, they actually, if they're done well, can reinforce each other. And to give you one example, we did the first ever a national health accounts exercise, a very rigorous exercise that demonstrated that, contrary to what most people believed, including many experts, the main source of funding for healthcare in Mexico had stopped being public allocations by government. People thought it was because there were a lot of public institutions and a lot of doctors worked and nurses worked in the public sector. It was mostly funded. We demonstrated that already in the year 2000, more than half of health expenditures were private out-of-pocket expenditures. People paying out of pocket because there was a failure in access and a lack of coverage from insurance. And we, for the first time, measured the fact that 4 million families every year became impoverished because their family experienced catastrophic health expenditures. Here's an example of how a poorly functioning health system then becomes a determinant of poverty, which then feeds back into worsening health. It's a double whammy on those families. They're already poor, hence they're uninsured. But by virtue of being uninsured, health, which should be the instrument to empower people to rise out of poverty, because of a poorly structured health system, deepens the condition of poverty, because it was most of that catastrophic expenditure happening in the poorest families. That was an invisible situation. No one had seen it, because although eventually we all experience serious health problems, we're all going to die, except on pandemics, at any given point in time, it's only a relatively small proportion of people who experience catastrophic expenditures. At any given point in time, although over a lifetime, most families will experience them if they are uninsured. So we were able to make visible the invisible. And that's actually the etymology of evidence. You are Italian, so you know this very well. It comes from videre, from to see, making the invisible visible. Bringing that to the fore and agreeing on the what. And the what there was, it is unacceptable. It is ethically and politically and socially unacceptable to have families who become impoverished because they get sick and they don't have the financial protection mechanisms and the access to healthcare. And it was actually very powerful evidence to bring consensus around from every political party. There were three main parties then, center, a left of center, a right of center. All of them agreed that that result was unacceptable. And that then drove a major piece of legislation. All parties voted to greatly expand public expenditure in health so as to protect families from the financial consequences of disease. And I say it's a textbook example of evidence-based policy, but evidence that then drives political agreement. Once we agree on the what is we need to treat healthcare as a right, and therefore it's unacceptable that people will become impoverished because of lack of financial protection for health. Therefore, that what was agreed upon, and then that was the hard, but we had to then bring forward
Hi, Dr. Frenk.
into the house, which was a little bit less complicated.
Alicia, trying to jump in? That's fine. I think there was a phone ringing, which is I think they were trying to stop, which is fine. So let me pick up on something you said, Julio, if I may, because I think you said something. There was something implicit in what you said, which is when you showed the data, this became clear it was unacceptable, and I think it's a really interesting point that you made. That is that it became unacceptable then to multiple parties. Now, when you say something becomes unacceptable, that's a moral judgment, right? Like there's value being attributed to it. And I've written before about our role in making an empiric argument and a moral argument. And I'm wondering if you can talk a little bit about the two, because your statements imply that actually the two are almost inextricable. And I actually find that very interesting.
Yeah, I do think following writings of a colleague that I'm sure you know, Michael Reich from the Harvard School of Public Health, speaks about three pillars of public policy: the technical.
Hi, Dr. Frenk. I'm so sorry to interrupt. It sounds like there's a phone ring. Is there a phone ringing over there?
Let me check, because that could be. Yes. You're right. It was a phone ringing here. I don't know why, but so my apologies for that. The idea of three pillars: the technical, the ethical, and the political, and if you assemble them right, those three pillars really sustain the edifice of enlightened public policy. The technical is most about the use of good data. You can use that data to drive that kind of ethical conversation. For example, what is unacceptable for a society? As we did with the data on the large number of families, mostly poor families, who were sunk into deeper poverty because they had to pay for healthcare. And that's fundamentally an ethical deliberation that then drives political consensus, that then makes action possible. And it is a very interesting example of how the three reinforce each other. And I think when we talk about social determinants, actually, I have found that it is that talking about the ultimate impact on health, because health has a huge political value. It's almost a naturally unifying topic in politics. You find it easier because it's such a fundamental aspect of the human experience. You find it easier to reach agreement. I'm worried about how the pandemic has actually started to erode that, as we have seen with the politicization of some of the public health measures like face coverings and vaccines. But that's a separate topic. We may come back to that. Traditionally, it's been easier to reach agreement, and you can then backtrack and make the argument that, for example, there are some interventions at the level of those determinants that are valued in themselves, but that have an additional value because of their impact on health. Example, expanding educational opportunity. It's valued in itself, but if you can then make the argument that then it also has the positive effect on health. And the other way around, I was able to argue convincingly with the finance minister that improving health was intrinsically valued, but that if, and in addition, if we did that, that would make the economy grow, which is the main job of the finance minister, because of that other directionality of causality, how improved health actually benefits the economy, competitiveness, etc. How having people not go into poverty because they are uninsured actually improves the savings rates, and therefore leads to valued economic outcomes as well. And so it is an interesting case how good data can actually drive that political consensus. And that's been my experience, that those three pillars actually can be made to function in harmony.
So every time you say something, I'm now thinking of 5 more questions, but let me try to explain myself. So let's talk. Let me be contrarian for a second about the current moment, and let's talk about the politicization, which you hinted at, and you said we may get to it. Actually, we get to it right now. So when we were grappling with the report, one of the things that we grappled with was about the politicization of data, and you talked a little bit in your comment about the politicization of health. I was wondering if you can talk about the phenomenon of, in 2021, the acute polarization of a lot of the conversations that we've had around health and around, I would argue, also around data. And I would argue it's much more so than it's been any time in the past 2 decades. So where are we at on that? And where does it leave us? And give me hope, give me rays of hope, because I also like to lean into optimism.
You know, I think the pandemic has had very bright spots and very dark spots. The bright spots has been mostly the amazing cooperation among scientists from all over the world, across sectors, obviously academic institutions, private companies, governments, everyone collaborating, that among other things have provided vaccines in record time. But the dark side has been the politicization of the pandemic, including the data about the pandemic. And, you know, unfortunately, the pandemic coincides with the rise of populism around the world and the erosion of democratic principles. This was going on before the pandemic. Mm-hmm. And, you know, our conversation today is focused on the Americas. The Americas has been an epicenter of that. And I'm not saying there's a cause and effect relationship here, but it is striking that the worst performances in the world actually happened, especially at the beginning of the pandemic, among those countries that had populist leaders. And if you look in the Americas, it was the United States back then at the beginning of the pandemic, Mexico, unfortunately, my own country, and Brazil. And, you know, some self-define themselves as, they find themselves as left-wing or right-wing populism. I think that's actually secondary. It's the populism that's actually the piece that's politicized the data. Because now this didn't start with the pandemic. We were already witnessing statements about post-truth politics. Mm-hmm. And of course, the rise of social media has only made that more serious. But one thing we saw among the darkest spots was the display of political leaders, heads of government, contradicting the opinion of experts. And if we go back at the beginnings, early, you know, February, March, even after WHO had declared the pandemic, presidents, and I mentioned those three in this continent, there were others in other parts, India, Turkey, other parts of the world. But here in the Americas, very notably, the three largest federal countries, all of them, with the presidents actually contradicting, minimizing the pandemic, saying it really wasn't such a bad thing, refusing to wear face coverings in public. All three presidents did the same thing. I will leave it to psychoanalysts in the future to analyze what is the psychological insecurity that leads a political leader to refuse to wear a face cover as a sign of weakness, when it is a sign of consideration for the others, which used to be a virtue for politicians. Showing that you care for others used to be something good for a politician. How did we end in that? And those behaviors were very similar. A discourse the populist discourse tends to polarize by pitching the good people, the people who the leader self-proclaims that he, and it's always he's, it's always men, that he represents, and the corrupt elites. And among them are the experts, are the scientists. There's been an attack on science, even though everyone then rushed to science to try to develop vaccines and save the day for their countries. But the discourse is fundamentally against evidence. And so in one of those contradictions of the pandemic, you had the general public exposed like never before I've seen to public health experts on TV, on social media. I mean, you were there, I was interviewed, a lot of colleagues. Dr. Fauci became a celebrity. We were out there in force at a level I had never seen, because people were really wanting to have information. And yet at the same time, this erosion by having them political leaders contradict a lot of that. And then all of that degenerated into this infodemic of disinformation and misinformation that's done so much damage during the pandemic, including now with fueling vaccine hesitancy, or vaccine refusal. Actually, it's not even hesitancy.
I keep thinking that the book that I really would love to read is one day a historian is going to write a book of just 1 month, the history of February 15th to March 15th of 2020, because I can't help but feel that the decisions that were made in that 1 month and the intersection of forces, political forces and communication forces, that really then determined the course of the world over the course of the next 2 years. And that 1 month was when we took a pandemic and politicized it to the nth degree because of the confluence of factors that we were in. So where is this going to take us? Like let's assume we will emerge from the pandemic sooner or later, hopefully sooner. What do you see as a viable path forward to detangle, to maintain the positive, which is the visibility of health, the role of health, which I agree with you, you and I are on the same page, the role of health as a potential unifier across sectors, but shedding the partisan lint that has accumulated with the narrative of health?
Well, I think we need to be intentional about that. I say, the pandemic has produced a lot of loss. There's been huge amount of loss, livelihoods. If you look now at the latest data on excess mortality at a global level, I chair the board of the Institute for Health Metrics and Evaluation, and the latest estimates are point to excess of deaths in the order of 14 million deaths. The official count is close to 5 million, but it's likely now. Part of that is not deaths caused directly by the virus, but deaths from other causes of death due to diseases that the care for which was delayed because of the mishandling of the pandemic. I mean, you have a drop in immunization for other things. Forget the COVID vaccine. In many parts of the developing world, you have delays in the treatment of chronic illnesses like cancer and others. So when you add both directly caused by COVID, deaths caused by COVID, and indirectly caused by the pandemic because of the deferment or people just being scared of going to a healthcare facility and dying at home from other diseases, it's an incredible toll. And we're still not at the other end so far. it's an incredible call. Even the causes that have been certified to be COVID, 5 million deaths. So a lot of death, a lot of suffering from the families, the patients, and then the impact, as you said, the pandemic magnified the pre-existing social inequalities, because obviously cases, hospitalizations, and deaths have been much worse in country after country in disadvantaged groups. The so-called essential workers, which were much more exposed to the risk of contagion, and who had the least access to personal protective equipment, tend to be people from lower socioeconomic status or from racial and ethnic minorities, underprivileged groups. The impact this has had on women, the gender dimension of the pandemic response. Women have lost jobs at a much higher rate than men. They have had to deal with the consequences of having children at home without access to school. The effect this is going to have on the loss of schooling for children. I mean, we are at risk of a whole generation of children who lag behind dramatically, and we gotta do something of a dramatic catch-up. And then you have this erosion of public trust by politicizing the pandemic and the spread of misinformation, the misuse of social media, which of course, was born with a great expectation that it would be a liberating force. How do we get out of that? It's easy to fall into despair, but that's not what we should do. We actually need to be invigorated by one notion, and coming again to ethical reasoning. Those of us who are still here, who didn't die, and those of us who didn't lose our jobs and experiencing the suffering, but are still here, have an ethical obligation to make sure that when we're out of the pandemic, what we emerge to is not a new normal, but it's a better normal. It would be, of course, unacceptable to just go back to the old normal. I think we've seen, for example, in terms of pre-existing social inequalities, how badly that has done. We shouldn't go back to that. But people talk about a new normal. I think we have a moral duty to really make it a collective purpose to build a better normal. And that means spelling out these different dimensions and deliberately try to do that. And I think there's widespread consensus on that what. The how is going to be more complicated than the example I gave, because it is an effort that has to develop in multiple fronts, many of them on those social determinants of health, many on rebuilding health systems. The health systems, the public health part of the health system, showed all its limitations. We have serious limitations on the global health system. I think we need to derive from this enormous amount of loss, this tragic loss of the political will to build a better normal. And I see a lot of energy around that. There's no shortage of proposals. And so that to me is the hopeful pathway forward.
Yeah, I'm actually delighted you mentioned that. I really like the notion of the moral obligation to move to a better normal. And the notion that, and part of things which I've been using in my writing and my speaking, is that COVID fundamentally illustrated what was there before to a place where we could no longer avoid it, where it became unacceptable to continue to avoid seeing things that we should have seen before. Let me switch tack for a second. I want to ask you about international differences. I want to talk a little bit about low-income countries, middle-income countries, and high-income countries. I was wondering if I could get your perspective on the place of social and economic determinants thinking in low-income countries, middle-income countries, and high-income countries. There's a lot of discussion now about global health equity. Some of it, I think, quite superficial, unfortunately. But I was wondering how you think we can leverage a social determinants agenda to advance health where it's needed most, namely low-income countries, and maybe whether COVID has offered us a fulcrum to do that.
Yeah, I mean, we have a very complex picture. When I started in global health, the world was a relatively simple world, right? You basically had communicable diseases, mostly the problem of poor countries, and then you have the non-communicable agenda, mostly the problem of industrialized, because that was the construction. I don't think it was true even then, but that was the simplification we had. So deriving priorities was fairly straightforward. You need to focus on infectious diseases, especially vaccine preventable diseases in poor countries. And then, the issues of heart disease and diabetes and mental health and cancer was a problem of rich countries. And we placed the low and middle income countries in that package. And that for some time, led to giving rightful priority to things like vaccination and dealing with common or infectious diseases. But I think the evidence that started emerging was that actually what was going on in low and middle income countries was a much more complex epidemiologic transition than the one that currently rich countries had gone through. And in currently wealthy countries, you had an epidemiologic transition that was largely characterized by a substitution of the leading causes of death from mostly infectious acute, and I think it's the acuteness that matters, and then for chronic non-communicable diseases. But I was involved early on in research that showed how non-communicable diseases were already rising at a much faster rate in developing countries, low and middle income countries. But the pattern was such that instead of a substitution, what you had was a juxtaposition of pathologies. And that's where the whole idea of the double burden of disease came up, which now we supplement with the idea of a triple burden of disease, by which I mean that in low and middle income countries, you have a triple burden of disease represented first by the unfinished agenda of common infectious diseases and maternal mortality, reproductive health events of which maternal mortality is the most important. Without having solved that, you already have the burden of non-communicable diseases that we used to think were most preponderant in rich countries. No longer true. The highest burdens today of heart disease, diabetes, obesity, mental health, cancer is in developing countries. And then if that was not enough, you have the health consequences of processes directly linked to globalization, because everything else is linked to globalization, but directly linked to globalization. The most dramatic example of which is, of course, pandemics. They affect all countries irrespective of level of development. But the other big emerging looming threat is the health consequences of climate change. So managing that situation in low and middle income countries, which traditionally have not invested in health and have not made that a priority, is a very, very, very important challenge. And that's where the data part of the 3D is so important. You need solid evidence to drive, first of all, priority setting, learning what works, and then to me, the importance of investing in evidence-based interventions, upstream interventions, is that with that complexity in the downstream, where you have this double burden of communicable and non-communicable, it turns out that the social determinants actually act on all of those. The reason why you have a country like India with the largest absolute numbers of undernourished and obese children, same country, but it's not that within India, obesity is a problem of rich, it's also a problem of poverty, of bad nutrition. And so if you can identify some of those upstream determinants that will impact multiple health outcomes, I think you have a powerful instrument there. And that's where the thinking about early interventions, again, not at the exclusion of having a well-functioning healthcare system that responds to the needs of people and prevents people from incurring in catastrophic health expenditures, as I was saying at the beginning. But that's where that makes sense. So, building what the Robert Wood Johnson Foundation has called a culture of health that acts on determinants that have multiple impacts on multiple specific pathologies makes sense in every country, but particularly in countries that are facing this very complex double or now even triple burden of disease if you add those threats from pandemics and climate change.
That's really interesting. It's the triple burden formulation is actually quite interesting, and I've been thinking a lot lately about the slow burning threats that we do not see right now that are coming, but they're so ubiquitous that we're not seeing them. And I like how you're linking them to fundamentally features of a more globalizing world. Let me shift course for a second and ask about education in the workforce, because one of the hallmarks of your career has been really, I think you've always had a focus on educating the next generation, on creating the best possible workforce. Can you talk a little bit about your thoughts about how an agenda, social determinants, data-driven social determinants agenda, intersects with what we should be thinking about the next generation, training the workforce for the future, and how should we be thinking about that both from the point of view of educators, but also from the point of view of learners, and how should learners be thinking about it?
I think it's a very important question. In 2010, to mark the 100th anniversary of the famous Flexner Report of 1910 that really shaped, originally was focused on medical education, but it had a broad medical education in the United States and Canada. That was the name of the report. It really had global impact, and it shaped not just medical education, but all the other professions. Of course, in public health, we had 5 years later, in 1915, the Welsh-Ross Report, which did the same thing as the Flexner Report. But for that 100th anniversary of the Flexner Report, we created a Lancet Commission sponsored by the Lancet. It was called a Commission on the Health Professionals for the 21st Century. And the report was published in 2010 on the 100th anniversary of the Flexner Report, and already provide a glimpse about some of the emerging trends and the challenges that these new realities had on the education of health professionals. And there were already a number of movements, and I mean, you've been chair of the board of the Association of Schools and Programs in Public Health, and as you know, there's been a big debate about the future. I was privileged to participate in some when I was dean of the School of Public Health at Harvard, and we did actually some of those reforms internally. And I know you're doing a lot of that innovation at the Boston University School of Public Health, and it's happening in many other parts. So we had actually planned 10 years after that report, so in 2020, an update, a follow-up. And of course, the pandemic also interfered. So we're now actually finishing that follow-up, and we hope it will be published early next year. But what I can tell you is that the idea of social determinants is very prominent even in the initial report. Because if I could summarize, one of the big trends, I mean, there's some big trends that are very positive. One is interprofessional education, the idea that we need to break out of these professional silos and build into the educational experience the reality of the workplace, which is work in teams. But you have a disconnect now, because once you're out there, you are working as teams, but in your education, we're all trained in this disciplinary or professional silos with separate schools of nursing and medicine. In the report, in the Lancet report, we actually even coined the term trans-professional to also include that part of the workforce that are not professionals, most importantly, community health workers, which are such an important part of action at the community level on social determinants. And so that movement towards interprofessional, a little bit less, I think we need to insist on the trans-professional component, ought to be built. You shouldn't wait until you get to the reality of work to find the challenges of teamwork. That ought to be a core component of any curriculum, because learning how to work as a team requires specific competencies. It's not something you pick up spontaneously. It should be part of the educational process. For example, it requires an appreciation for different perspectives, the development of the capacity to disagree respectfully, and through a process of persuasive communication, come to an agreement and be able to mediate disagreements that you may have in any team. In the case of working effectively with community health workers, it requires sometimes cultural literacy, understanding different ways of framing health and disease, or different ways of understanding social determinants. So that's being one big piece, and I see a lot of progress on that front. Not as much as we need, but certainly our follow-up will document that interprofessional education has really taken off. The other has been the rise of technologies, and here this is one of the bright aspects of the pandemic. It accelerated. It didn't create the use of technology to expand access to educational material, but it greatly accelerated that trend. And I think we need to build on that momentum, because every university went, at least at the first few months of the pandemic, onto remote learning and had to adopt and adapt. And I think mostly what we saw was a cultural change in acceptance by faculty, who tend to be very resistant of some of those technologies. We need to build on that. But and then of course we've seen the explosion. I mean, 2012 was the famous year of the MOOCs, the rise of MOOCs and other platforms to really improve access. But to me, the key switch is that increasingly we need to move along 3 levels of learning. That I think is one of the most interesting formulations in the Lancet report. The first level we call informational learning, informative learning, the second formative learning, and the third transformative learning. Informative learning is what it says. It's about having a corpus of existing accepted information, knowledge that's dynamic, that's constantly being renewed, but making sure that everyone masters that corpus of facts and skills that form a profession. But that only makes you an expert. It's a very important part of education. It's unfortunately what we spend most of the time educating, but and it is important, but it's only the first step. You need to build on that towards formative learning, and that is the process through which experts get socialized into becoming professionals. A profession is an expert, what you get with informative learning, an expert that has been socialized into an ethic of service, the idea of service. And then you need to go further to the third level. Transformative learning makes out of health professionals not just experts and professionals, but agents of change. That means deliberately building into the curriculum the development of leadership capabilities. And the key thing there is learning, if you're going to be an agent of change, is the idea that those health professionals, doctors, nurses, public health professionals, and all the other health professions need to increasingly master not just the content, but the context of their practice, of their professional practice. Because what we've done traditionally is develop experts, that informative learning, that master the technical scientific content. And that's very important. We want competent people there. But increasingly, you need to understand the context. If I am providing care in a particular facility, who is never coming here? How do I understand that my goal is not just to provide healthcare? I need to do that at the highest level, but actually to increase levels of population health. How do I understand the organizational context in which I live and how the health system in which I operate is, for example, making a lot of poor people poorer by not protecting them financially? And I don't think you can anymore be an effective member of the health workforce if, in addition to mastering the content, you don't understand the context and decide to also be an agent for transforming for the good the context. And a lot of that context, in fact, I would argue all of that context, is what we otherwise call social determinants of health.
I've also found that informative, formative, transformative are quite helpful, actually. Let's talk about context for a second, talk about the public. We've talked about scholars and we've talked about decision makers and we've talked about students. Let's talk about the public, because there really is no progress in changing the conversation about things that matter to health without actually having the public be involved in that conversation. And in the commission, we talked quite a bit about the democracy of data and about the need for accountability of decision makers to data collected from communities and bringing the broader population along in understanding the need for data and accountability decisions built on that data. I was wondering if you can comment a little bit, maybe leaning perhaps on your experience as Minister of Health, but also broadly in many other sectors, about our role and how we can engage in transformative efforts to change the public conversation on health so that we can make this conversation that you and I are having lingua franca, so that it emerges from sort of the ivory tower, so to speak, and becomes how health is understood.
That's critical. And well, let me tell you what we did do, because again, you need to be deliberate about this. So when I was appointed Minister of Health in the context I described yesterday of the democratization, the first democratic election, the title we gave to the strategic plan for the Ministry of Health was the democratization of health. Because the context that I was talking was, here's a country that finally is taking the step towards democracy. And my whole point was, this is great, but the transition to democracy doesn't end with the democratization of political rights, the right to vote most notably. It has to include social rights. And that therefore led to having that overriding construct of the democratization of health as a driver of our policy. And something that might look very technical, like that insurance program we designed this was mostly for people that didn't have a salary job, because in Mexico, like in the United States and many other countries, employment was a determinant of your access. And that meant saying, no, this is a universal citizen's right. It cannot be mediated by the fact that you have a salary job. Everyone needs to have access to insurance. So we created a public insurance plan for the uninsured, which most of whom were people not in the informal sector, but people who work by their own. The largest group of whom were peasants who were uninsured because they didn't have an employer, and therefore very poor people. So, that was the idea of democratization, but we accompanied that with the organization of something we called an annual event called the Citizens Forum on Health. And what we did is we produced a report, not the typical bureaucratic report that we had to send by law to Congress and to the Ministry of Finance, and which is very important for accountability with, lots of numbers that no one reads. We produced a very visual report, and we ranked the performance of the states. Mexico is a federal republic with 32 states, on outcomes that were easily understandable by people, including some that reflected, for example, poor nutrition, lower educational levels, low allocations from the state level budget for health. And we would convene, we had agreed on the state level secretaries of health on that set of, I think there were 30 indicators that we would report and compare and do a sort of scorecard that would be made publicly available. And the idea was this citizens forum, we would bring together and would invite all the NGOs that were active, civil organizations, political parties, everyone was invited, and we released that report and explained. And I have to tell you, the pressure that the state secretaries had from their governors, when it turned out they were at the lowest part of the ranking, because they had the lowest coverage, and some important dimension was very important. But the most important thing is it mobilized the civil society to demand services. And my theory was that to move the bureaucracy, we needed that external force. And it was a key part of the idea of democratization. I think now, with what we've seen with the mis and disinformation spurred by this wave of populism, acting in conjunction with social media in the middle of a pandemic, involving the public actively is important, because Dr. Brundtland used to say in WHO, there are communicable diseases, and then there are communicated diseases. And mis and disinformation can be more serious communicated diseases. And so I think part of that better normal has to be a reinvigorated impetus to double down on community involvement and engagement as a major, again, it's not one or the other, it's a way of acting on social determinants. It's also a way of pushing the formal healthcare system to perform better and to make itself accountable to the people that we're supposed to serve.
That's actually that's a really interesting story. Okay, I have 5 more questions, but I'm not going to because I'm looking at our time. So I'm going to ask one last question. Can you, these conversations are watched by students, and which is part of the intent. Can you tell a story about what motivated you? And you've had a wonderful path in so many aspects of public health. And what has motivated you? What has informed what you have done in these many roles?
Well, you know, I can tell you what's the motivation. I'm the child of refugees, people escaping from the horrors of fascism in the 1930s and finding refuge in a country that was much poorer, Mexico, than Germany, which was the country they were escaping from. And you know, that made my life possible. So I have a very strong sense of this idea of generosity towards strangers. It's easy to be generous to your family members and friends. But when my grandparents, with my father, who was 6 years old, arrived into Mexico, barely speaking the language my grandmother, looking very different, it was a generosity towards those strangers that saved their life and made my life possible. But to me, that then the story that I think will resonate with some of your students is I was a medical student living in a very unequal society. Social inequality in Mexico is the big scourge of Mexico and most of Latin America and many other parts of the world. So at some point, much as I loved clinical practice, I was getting restless at saying, but you know, why do people get sick in the first place? What can we do to avoid? I wasn't using the language of social determinants, but that was very much in my mind. And that was during my internship where I made the critical career decision that instead of pursuing what would have been a standard residency, and I passed the education, the ACFMG, the exam, you know, just to make it clear that I wasn't avoiding that because I wasn't good enough. And I decided to go into public health because I saw that as a pathway for acting on the upstream determinants. And I was very aware. And because I was a very good student, some of my friends were very distraught, and my teachers, and said, does that mean you're going to give up seeing patients? And I said, no, it just means that from now on, society will be my patient. And that's when people say, so what do you do in public health? I say, public health, you are in public health when society becomes your patient, when you understand that what you're doing is acting at the level of the entire society to improve health. And so that was the insight I had in the middle of my internship in a hospital, enjoying very much clinical care, but saying, I'm very rewarded by helping one patient at a time. And I think this is incredibly valuable, and we should always value and reward those heroes that are at the front lines. But I want my own impact to be by acting at the level of society as a whole. And that instead of doing what would have the same number of years it would have taken me to do a residency, I invested in getting a PhD in public health and embarking in that pathway.
Great story, thank you. Dr. Frenk, it's really a privilege to have this conversation. I actually only wish we could continue it much longer, and I look forward to many more such conversations. Thank you for taking the time. Thank you for everything you've done, and thank you for being a part of this discussion.
Thank you for that excellent work of the commission, the 3D commission. I think it's good.